I'm going to rewind to about 20 years ago. And actually, I'm going to rewind to 29 years ago when I was 11 years old. So I've just aged myself. I grew up in the UK. If you can, perhaps you can still tell that. And at the age of it, I used to come to India and Pakistan very frequently because my parents, my dad is from India, my mother's from Pakistan. So I would frequently visit both countries. And I was really, I guess disturbed is the right thing to say, by the level of disparity between rich and poor, between the haves and the have-nots, between the top of the pyramid and the bottom of the pyramid. And it was striking, coming from a country where everyone had access to healthcare, in this case the UK. So then at that point, actually, at the age of 11, my mother actually brought us back to, my dad passed away, so my mother brought us back to Karachi in Pakistan, big metropolis. And there my mum had a maid who had 6 kids who were my age, within my age range, between, at that time I was 11. And these were my maid's children, extremely intelligent, very aspirational. If you'd ask them, what would you like to become? One would say, I'd like to become a teacher. Another would say, I'd like to become an astronaut, believe it or not. They used to watch TV regularly with us. We grew up with them. And I had a very rich experience with them growing up. And then I shipped over to the US for college. And in my first year of college, I heard that their dad, who was a mechanic, had a stroke. And what ended up happening was that all of these children who by that time were in secondary school or post-secondary school or in graduate school basically were put into urban child labor or urban labor situations where they ended up having to, in order to be able to pay for the ongoing medical expenses of their dad. And that one experience really stayed with me and struck me that, a single catastrophic medical event, that's something that had such a huge impact on that family and on that generation. And that generational poverty basically was assured for this, for them, because of, essentially once you're in the urban labor market, especially child labor, it's a one-way ticket. So that really got me thinking about what we could do to actually socially protect these individuals and build a system where they would have ongoing access to quality care. And that's kind of how the genesis of Naya Jeevan took place. And then training in the US in surgery and being on the receiving end of the insurance system there as a provider who often had to battle with insurance companies, I just felt there was a much better way. The system was broken. There was a much better way, more efficient way to deliver healthcare. And so I started looking at opportunities where one could actually apply what we were learning in the developing world and apply it in the context of other countries in the developing world, but also the developed world, in this case the US, where 50 million people are uninsured. So I just wanted to share that with you, but I'm happy to answer other questions.
First of all, I think I'm a little bit older than Asha, but I'm not going to give it quite away. So you understand broadly my direction. Half my career has been angry outsider. I campaigned in developing countries against the pharmaceutical industry and the way they were promoting pharmaceuticals. I joined the Consumers Association and Which magazine, and my first part of my life really after college was telling professionals what they should give service users and patients as their rights. And during that time, I had a nervous breakdown when I was 25 and went through the psychiatric system for 6 years and came out perhaps angrier than I'd gone in, and continued my campaigning when I came out, more local than national or international at that time. And then the latter half of my life has been more about supporting organizations to listen. And so I developed a network of freelance consultants 4 or 5 years ago, which supports organizations to undertake user or care or patient involvement in different ways. And as we started to do that, I tapped into the experiences I'd had as a mental health service user and began to be interested in learning and development, and realized that what I had lacked at each stage of the way was clarity of my role as what we are now calling patient leaders. I had no training, as we called it then, no learning and development, no practical support to take part, and we were facing across the table, literally and metaphorically, professionals who had immense resources, power, professional expertise and credibility, and were marginalized in 150,000 ways at strategic level. At the same time, the NHS has got better at getting feedback from patients through surveys, through focus groups and stuff, but hardly ever uses it. So we have an engagement industry now in this country which gathers data, marginalizes patients at strategic level, and doesn't provide any learning and support. However, what Mark and I have become very, very aware of is that there are thousands of people volunteering their time. So there are patient representatives, there are activists, there are campaigners who are, if you like, trying to transform the system. Meanwhile, you have a huge and growing number of people who are in the community supporting well-being, public health projects, peer-to-peer mentors, coaches, etc. And what we've developed together, we were given a little bit of funding to pilot and evaluate, was originally a patient representative program using the techniques that Mark has utilized in much of his life. So we've developed something called the Effective Patient Community Representative Program. And what that has changed into is, as people come into the room, they're not just representative, they're a wealth of different sorts of leaders. So what we have now is an effective patient leader program, and we are trying now to build the infrastructure around that so we can grow the model, grow online learning, train the trainer approaches, train the coaches approaches, so we can spread that model and create, if you like, a social movement for change through patient or service user leaders.
I think the thing that's really good about combination of David and I is that we have slightly different angles upon which we approach this, but the one thing that commonality between us is our experience as service users. So I developed rheumatoid arthritis in my early 20s, and that experience of, as a young 20-year-old man, going from being very fit and active to being unable to basically move or take part in anything. And my experience of working or being treated by the medical system, where I was seen as a set of symptoms to be treated, and yet they were very good at lifting the bonnet of a car and tinkering with the engine, but they weren't very good at understanding it as a 20-year-old man. I didn't know who I was now that I had developed rheumatoid arthritis. So I went on my own personal quest, my own personal journey to make sense of who I was and what it meant to have arthritis. And I engaged in a number of trainings to do that. So I trained as a psychotherapist, and I trained as a coach, and I started off in education anyway. And I used all those skills to volunteer for a national charity in this country called Arthritis Care. And I ran a number of programs for newly diagnosed people with arthritis that was focused on empowering them to reflect and grow as individuals and see themselves as more than their condition. And this experience led me on to develop a number of programs linked to this, and that is basically the route at which took me to meet David. David and I met in a circumstance where we both went to an organisation called the School for Social Entrepreneurs with ideas to try and develop projects, and we met through that and realised that we shared a lot of commonality and a lot of ideas. And so we, as David said, we came together, we put this program together. I think the key thing that makes this program very different is the idea of working on the, we work with individuals and we talk about helping them to lead their lives, personally lead their lives. So the metaphor of becoming great personal leaders of their own lives. And once they've developed those skills and insights, is then to say, right, let's look at leading others. How can you lead others? How can you move forward? How can you motivate and help others to take more control of their lives with their conditions? So that's basically.
So in Pakistan and in many other developing countries which have a history of corrupt regimes, you're guilty until proven innocent. And what that means is that even if you're engaged in some kind of philanthropic activity or something which has social benefits, people view you with great skepticism. They may think you're a fly-by-night operation. So you have to establish credibility, and that takes time. You have to establish a track record of performance, and that, in the beginning, that can be very, very challenging, especially where you're engaging. In our case, our model is very corporate-centric or institutional, and so going to big corporations as a startup social enterprise and trying to convince them to cascade our health plan up and down their supply chains. They initially thought, who you just landed from Mars, and this is not how we do business in this culture or in this country. And so I think we lost Eva there, maybe.
I'm still here.
Just the image. Shall I wait?
No, go ahead.
Oh, you can hear me?
Mm-hmm.
Oh, okay, maybe it was just... Sorry. So what I was saying was that I think the challenge of the culture or the country in which you operate is definitely something that one has to take into consideration. The other aspect of many countries which have a post-colonial history is that in many cases there still is this kind of hierarchy. There are these affluent people who either historically have been landowners and have continued to and they continue to perpetuate the status quo. They actually don't want the system to change. They want to be able to dominate and continue to rule over, low-income beneficiaries who serve them. And they are actually a major barrier to social innovation because they don't want to empower the base of the pyramid. They actually really like the status quo. So that's definitely a challenge that we've been confronted with, which is kind of what I call the post-colonial feudal mindset. But that obviously, when you have a challenge, it also makes you want to overcome that challenge. So it's been an interesting journey.
I think what Asher is talking about very, very powerfully is about power, and I think that's what we're dealing with too in different ways. In the sense that if one imagines that the NHS in England has been a 50-year war between the power of doctors and the power of managers, if you're bureaucrats, and all conversation, all training, all conferences you see being advertised are about leadership for health professionals. So one of the major tasks is to convince the powers that be is that there is a different form of leadership that's required, and actually convincing people on both sides, the doctors or the clinicians, the managers, and ironically patients and participants who want to come on the program, that you need a new form of patient leader, and patients can be leaders, and I think people don't yet understand fully the significance of that, and B, that this is a new form of learning. So the strapline really is, it's a new form of learning for a new form of leader. And I think in that you've got challenges to persuade, as I say, clinicians and managers and participants and stroke patients themselves. Often what we find when people come on the course is half an hour in, they say, blimey, this is actually what we've needed most of our so-called professional life. But that it is, within the question, there is the marketing challenge.
Yeah, I would add a couple of things to that, which echoes what David said. One, the model of leader is very much about expert. So it's about the expert and it's about the power thing. And it's very paternal, and it can be quite patronising. So it's the family, it's the mother or the father looking after the children. So the patient often gets taught at and felt like a child. Now the trouble is, as they come on our course, they get caught in that model. So they too want to become an expert. They too want to be able to tell the medical professionals how to do things. So if we're not careful, we get caught up in perpetuating the old structure. Our leadership draws very much on the model of the servant leader. It draws very much on the facilitative approach, collaborative, co-production, and it's a whole new model. And of course, as David said, the individual says from their own perspective, wow, this is just what I need in order to build my own confidence. You know, there's a lot of pressure on me to be charismatic, to be ego-driven, to be this leader in control, and it's very seductive. So the misconception is basically that they expect us to replicate, just turn the power so that now the patient has the power against the medical professionals, and that's not what we're about. This is about collaboration.
For me, providing information to patients in the way it has been done in the past perpetuates the power model that Mark's been talking about. In fact, we, in our programs, give less information. We think less information is more. So instead of lots of people come into our program saying, we want to understand the system, we want to understand how to get back at professionals for what they've done to us, either angry or they're too grateful. And actually, we provide them, instead of the map, we provide them with the navigating skills. So while I think information often is power, I think often the skills needed are more about the antennae, the radar, the way of understanding power and the way of navigating the power structures that are in there. That said, information is often very necessary, but in our program, it's not the be all and end all.
What we give them, just to reiterate what David says, is we give them the dialogic skills to get the information that they require. So we are not about giving them the information, we are about giving them the tools to access the quality of information that gives them what they need. So they come away with the dialogic skills of being able to ask incredibly powerful questions of medical professionals. And that in and of itself is a radical departure. Medical professionals are not used to having somebody ask them a facilitative question that is not going to show them up, and you often get the medical professionals going, you know what? I've never thought of it that way. Thank you. You know what? Yeah, that's a really good way of looking at that. Yeah, I wonder what the answer to that is. So they go on this journey of finding answers together. So to put it succinctly, it's about giving them the skills to get the information.
Interestingly, up on our side, we try and give our members, our low-income beneficiaries of our health plan, 24/7 access to doctors, so they can actually ask those questions. They literally do ask them those questions. And certainly, we try to be judicious with the timing, but it's 24/7 access. We found that to be very, very empowering for patients, for low-income, for our low-income members. The other thing that I wanted to speak about is the information asymmetry that exists between the developing and the developed world. So in South Asia, which is the region that I'm right now most focused on, there really are two tiers of society, and the lower tier doesn't really have access to the same type of, or they're not participating in the digital economy, let's put it that way. However, we found that many of their family members, relatives, may have gone to distant shores, whether in the UK or the US or the European Union, and the diaspora can actually be a huge source of information. And so we've actually started leveraging the full expertise of the diaspora, as well as their resources, capital, human capital, as well as financial capital, to cross-subsidize in this case, the healthcare, but it could be any service, of their significant others, relatives, distant relatives, or any designated person for that matter, to try and bridge that information gap.
What is exciting to me is 2 days ago we ran a session, and one of our participants, who's a mental health service user who seems to have lacked a lot of confidence, came up to me and said, I've just been asked to go on a ministerial advisory group to look at the national future for mental health, and I wouldn't have been able to do it without this program. And another participant said, who's been campaigning on sickle cell, because his son had sickle cell for many years, has just been asked to contribute to the national commissioning of sickle cell services in this country within the new NHS commissioning board. And that's what excites me, just the direct feedback from course participants. And it's not that we've suggested that they go and do that. They have found these opportunities for themselves. What has also excited me and riled me up in equal measure is the immense interest amongst the charitable sector. All sorts of people who say, we really, really, really want to do this. And then there's this pause. They say, but there's no money. And then I hear in NHS leadership circles that still, despite the recession and despite what you think of, is that thousands and thousands and thousands of pounds are being given to consultancies to re-engineer different parts of service improvement pathways without involving patients. And I think it's a bit like the asymmetry that Asha is talking about. It excites me and frustrates me in equal measure that there's such a need for this, and yet they don't know what they need, and the people that have the money need to be persuaded of the tangible, specific benefits, and somehow we've got to close that gap between the desire on the one hand and the blindness of those who have the power.
There's no doubt that in the groups we've worked with, we can see a cultural change happening in the way they behave, in what they believe, and how they see the world around them. And in engaging in others with that new way of seeing things, they are influencing those people by their very presence. And we are seeing changes happening. And what is really powerful and what excites me is that people come on the program because they want to make a difference in some element of their care with the medical professionals. Yet the skills they learn help them to take that empowerment, co-production, facilitative model back into their communities. And they get involved in different elements of their communities. And we see mothers and fathers changing the way they talk to their children, asking questions, listening differently, facilitating the youngsters to take action in different ways. So what really excites me is there's this way of being which is actually translating into other areas of people's lives.
And one thing I'm particularly excited by is the notion of frugal or reverse innovation. So there's a lot of innovation occurring in developing markets, developing economies that have distinct and very consequential applications in the developed world. A good example, I'll give you three quick examples. One, an Indian friend, his name is Suneet Singh Tully, has come up with a $35 iPad-like tablet, which completely opens up access to information to an entire a massive population that formerly was excluded from, again, the digital economy. And that's going to have tremendous consequences. There's a push towards providing non-diagnostic, non-prescriptive patient service information from the developing world across to the developed world. So you have fairly well-trained English-speaking physicians, both in India and in Pakistan, who, for a fraction of the price, are available to provide what I would say is to be a health coach or a coordinator, or somebody who's available as a patient advocate, similar to what Mark was referring to earlier. And I think that model is actually going to have a very telling impact on the developed world, because the cost of providing that type of care through a link such as this is very, very low. So I do see, especially in the United States, where there are 50 million people who do not have health insurance, which is a staggering number, and mind-boggling for a developed country, that there's a tremendous opportunity to source services from outside, beyond borders. And that's where I see this kind of transnational or transglobal, the cross-leveraging of human capital from different parts of the world to different parts of the world.
The interesting thing is that if you talk to doctors' leaders, the doctors' leaders who are on that recognize that it's incredibly difficult for them to maintain this position where it's incredibly stressful to be seen as the expert, for people to come into their consulting rooms and expect the doctors to have the answers,
Mm-hmm.
and to make it all right for them and to fix it for them. And yes, it plays to a lot of their egos, it plays to a lot of their power, and yet a number of doctors say, if only we had the ability to have a different relationship with the people that we treat. Now, it's incumbent on both sides, because my experience is, with a lot of people who come on our programs, there is an element where they expect to be fixed. So, they play out the same game that's being played out by the doctors. So it's a two-way thing.
Well, I think that if you look at the way that traditional healthcare has been delivered in the Western tradition, I think that it has been a very hierarchical system, and as Mark and David pointed out, it's been very much control-oriented. That control is now slipping with the flow of information across countries and across the internet, and so I do see, and of course, you again, as I said, you have well-resourced and well-educated human capital in many, many developing countries that can provide very, very helpful services to patients anywhere in the developed world. That's not to say that they will replace doctors or physicians in the developed world, but I think that they will complement them and do so in a way where patients really become much more participatory in their own health and wellness, and are much, much more engaged and much more proactive, and don't feel that there's some magic, someone's going to sprinkle some magic dust on them, but that actually they have a very active role to play in their own health. And I think that type of health coaching, health coordination, whatever you want to call it, is going to become the norm. I think physicians are apprehensive, especially in the US, where they stand to lose a lot of money. But I think that, as with any industry, innovation breeds more innovation. And so you'll see, even within the medical field, I'm sure you'll see tremendous strides and tremendous opportunities for for whether it's for technically gifted people or others who want to kind of who can still maintain their living standard. From a patient-centric point of view, I think the outcomes will be better, and that people will demand what I call pay for performance. Both patients, insurance companies, payers, sponsors will actually start demanding of physicians a kind of a pay for performance as opposed to a pay for procedure.
It sounds like we're talking about, on the one hand, a range of patient engagement. On the one hand, of patient empowerment actually yielding a higher relationship with the doctor and engagement that actually leads to better care. And on the other, changing the way the doctor views his role in the entire process.
I did realize how unbelievably hard it would be to raise social capital to finance what we're doing. And maybe I was living in some blissful ignorance back in 2007 when I quit my job to start this. But in retrospect, I shouldn't have done that, because I've put the organization through 5 years of bootstrapping now, and that may not be sustainable for some of my colleagues. It's definitely been a tough experience for many of them.
I'm really interested in it, Mark, because of the conversation we were having even this morning. I have my own consultancy, and my difficulty is freeing myself from that to have the development time, the room, the space to develop these ideas, which if I'd had that space before, I think we could have been up and running a couple of years ago. So there's the grass is always greener, Asha. In some ways, I wish I'd done what you've done and quit and put all my time on this, and maybe we'd be up and running even faster. So I don't think there's one way. What I do think is it takes an enormous leap of faith to believe in the vision, and one can say that, but actually, when you get a decision to be made, right, we're going to do something by December, which is what Mark and I have committed to this morning, there's a sort of intake of breath and thinking, blimey, actually, am I going to do that? Do I believe in this sufficiently to pursue it? And we do, but there's something about faith in the vision or faith in the intention, which is not blind, but it's about identifying the next steps towards it. I don't know, but for me, it's all about confidence and dealing with self-doubt.
If I knew 5 years ago that it is about having the passion of your vision and the belief and the real courage to stick with your beliefs, and then to manage all of that passion with the practicalities of learning the language of the people you need to connect with in order to get your ideas heard, and that passion is not enough when it comes to these people. They want to know, how's this going to help me? How can I get a return on this? And it's that balance between learning how to balance my passion and my vision with the practicalities of talking the language of others.
Over the last 5 years, we've seen the emergence of what I call the corporate social intrapreneur, which is a new species of people who are leveraging corporate resources while they're working for corporations for social impact. I've seen people do this in the pharmaceutical industry quite well. I've seen people do this in not so much the banking industry, but I've seen people do it in other industries fairly well, where they've actually leveraged the resources. Now, I don't know whether their bosses or their shareholders were very happy with them, but they certainly created lasting social impact. So I think that even corporations are beginning to wake up to this reality that in order for them to be sustainable and for them to have sustainable, successful businesses, they have to have social impact embedded in their DNA.
This is about a different form of leadership that will affect health systems and will get patients and carers and the public able to influence policy practice, at all sorts of levels. And these are people who are opening doors for others to come through. There is a phrase in the English NHS which is really horrible, where professionals, managers and doctors will say, we don't want the usual suspects sitting at the tables. I don't know whether you've heard that phrase. People who have a personal agenda, as if sometimes there was anything else, really. And what we are in the process of developing is the unusual suspects who will challenge our systems at source, at policy level, at practice level, at national, regional, wherever.